So this is the humerus, and this is quite a comical bone, but a good one to know and be familiar with because we come across it a fair bit. So let's look at the main parts, which is important. There's the head, which forms part of your glenohumeral joint. There's a neck, and there's an anatomical neck and a surgical neck. There's a shaft and body, and there's a base that has a medial and lateral aspect to it. And we'll easily identify which is the anterior and posterior surface. It's pretty easy. There's two bits that give it away. One, there's this groove here, which is the intertubercle groove or the bicipital groove. And if you always look here, there's this, the olecranon fossa, and that's really where the ulna articulates with, so that always gives it away. And as soon as you find that, you'll know that that is the base, the posterior. And so if that's the posterior aspect, and it sits there, then this is your medial epicondyle, and that's your lateral epicondyle. So this is the left humerus. Let's look at the head component here. So the head articulates, as I've said, with a glenohumeral joint. It's really important just to look at the intertubercular groove, which has a lesser tubercle and a greater tubercle. And the important things about this are the muscle attachment. So the lesser one has a subscapularis that comes from the subscapular fossa of the scapula and inserts onto here. And then it has the intertubercular groove, which you sort of jump over. And then you think of it as this way: the greater tubercle going from anterior to posterior. Think of it as the rotator cuff muscles sitting on it almost. And I use that. So that's supraspinatus, infraspinatus, and teres minor towards the rear. And if you follow the lesser tubercle down, that then basically receives the attachment and forms the medial lip of this intertubercular groove, and that receives the teres major. Whereas the greater tubercle forms the lateral lip, and that receives the pec major. And in between is lady di, between the two majors, latissimus dorsi, between the pec major and teres major. That's a really important bit and good to know about. The other aspects that you can look at on the posterior aspect are the anatomical neck and the surgical neck, and this is important as the anterior and posterior humeral arteries that come off the third part of the axilla wrap around, so does the axillary nerve. So if you have a posterior dislocation, you usually get loss of that sensory component of the axillary regimental patch and some function of your axillary nerve, which supplies deltoid and is important for abduction, abduction of the arm. So if we lay it back and we concentrate and work our way down, important to find this proportion here, this is the deltoid tubercle, and then it takes you down into the lateral supracondylar ridge and the medial epicondyle and lateral epicondyle. And these two people always get confused about. Essentially, one is the trochlea and one is the capitulum and capitulum. And they're hard to know, and the easiest way I use to try and differentiate that is, this is my little trick. If you look at that, that to me there looks like a T. So I say that's always the trochlea, and that is where the ulna articulates with, because the back of the ulna goes into the olecranon fossa and it always sits there. So that is that sort of T shape like that. And then that basically means that the radial head always articulates on the lateral side, and that's always the case because on the medial aspect, as we know, the medial epicondyle on the rear houses the groove for the cubital tunnel, and that's where the ulnar nerve can be entrapped, whereas the lateral one, supracondylar, can have problems with the radial nerve and injury to that as well. So then we talk about important structures that go around this bit that we've spoken about: ulnar nerve, radial nerve. We spoke about the axillary nerve and posterior humeral. Then the most probably important one is at the rear posterior side, and it's the groove here, which is the spiral groove, and that's where the radial nerve comes round and winds round. And that's your classic injury for saturnatic palsy, or a stab wound to the rear of the arm, or a mid-shaft humeral fracture that's plated, and then they get hand drop, wrist drop, etc. And there's usually a radial nerve entrapment. And with that lies the profunda brachii artery. And remember, it comes out of your triangular interval. And that triangular interval is formed by the boundaries of your long head of triceps, your humerus, and the teres major. As it exits, it wraps around there. Important for us as well in terms of flaps is as the profunda brachii comes off, it gives off branches, usually the radial collateral that goes laterally, and there's an anterior and posterior branch, and it's the posterior branch of the radial collateral artery that's the basis of the lateral arm flap. That's important. There's a medial arm flap as well, but I've never seen that raised, so let's see. Then muscle attachments, so they're important, and I'll try and keep them in groups because it's a bit easier to remember. But we spoke about the muscles at the lesser tubercle, greater tubercle, the intertubercular groove, and they go in sort of threes that way. And then on the posterior aspect is a nice way to think of it. Always find that deltoid tubercle, and just below the lesser tubercle sits the lateral head of the triceps. Then you have your spiral groove, and then you get your medial head of triceps. And the long head, as we know, inserts into the infratubercular groove of the glenoid fossa. The other ones to then look at on the distal base, on the posterior surface while we're here, might as well have a look at, is the common flexor origin, which is on this side, and just proximal to that, that's where the flexor carpi ulnaris and the common flexor origin are, and just on this aspect will be the supinator, and they'll even be part of the common extensor origin, but really you won't see them until on the anterior surface. So again, think of it as three. So there's your deltoid tubercle, then here is brachialis with coracobrachialis as well, and then your pronator teres and your common flexor origin. Whereas on the lateral aspect is your brachioradialis, your ECRL, and then your common extensor origin. And remember, there's that mobile word of brachioradialis, ECRL, and potentially you can group ECRB with it, that the radial nerve supplies before it then goes down into your wrist, finger, thumb extensors, and then separates into the superficial radial nerve, purely sensory, and the PIN, posterior interosseous nerve. A few important things happen at the mid-humeral level, and we've sort of touched upon them, but there's the insertion of deltoid, there's the radial nerve that runs around with the profunda brachii, and it gives off that branch. There's also the insertion of coracobrachialis that comes on the other side, and sometimes you have the basilic vein going up along it, with the ulnar nerve as well, passing posteriorly through the intermuscular septum, piercing it, and the median nerve crosses the brachial artery as well, here as well. So there's a fair bit going on that side, and that's usually on this aspect here.